Okay, so let's move on to constipation. So constipation is a very common condition. Older people often have constipation. Younger people can definitely have it as well. Medications can lead to constipation. Uh, Opioids for pain. Calcium channel blockers are constipating. There's many medications that can cause constipation. And I mean, constipation is very treatable with stool softeners and laxatives. And you really want to avoid patients getting constipated because they end up straining, and straining can lead to a number of other conditions, right? So at the top there it says constipation is one of the leading causes of hemorrhoids and diverticulosis. So hemorrhoids is really just from the straining, and you push out hemorrhoids. The diverticulosis, we'll get to that in a minute. So let's just talk about why is there so much constipation, even if we take out medications. Well, the large intestine really wants to absorb as much fluid as possible. Because your body wants to keep fluid, and then the kidneys will get rid of the fluid as needed. So the large intestine is responsible for reabsorption of the fluid. So if you have insufficient fluid intake, the large intestine is still going to take as much fluid as possible out of the stool. Okay. Insufficient fiber in your diet. So fibers bulk up the stool and prevent constipation. So it's important to make sure people are getting proper amount of fiber in their diet, proper amount of fluids as well. Exercise is really important. People lying in bed are very prone to getting constipated. The bowel doesn't move as well. Peristalsis is reduced. So getting people up out of bed and doing activities avoids constipation. And then the last one, of course, is this would apply more to children. Ignoring the urge to defecate. So if you're ignoring the urge, you're in a way you're training the bowel. So you're ignoring a signal from the bowel that it needs to empty. And that can be a problem if you do it for a long time. And children can run into problems getting very constipated because they want to continue playing or they want to continue doing something with their friends, and they ignore the urge. We try to avoid daily laxative use. The bowel can get very accustomed to daily laxative use and become very lazy without it. So daily laxative use is highly discouraged. Stool softeners are fine. Many older people are on stool softeners daily. The issue with the laxative is causing a lazy bowel later on, after months or years of using a laxative, that your bowel in a way becomes dependent on the laxative. So we definitely avoid them in children, and we try to avoid them in older people. It's not always possible to avoid chronic use of laxatives. What else on this slide? Do not ignore your patient's bowels. That's a good idea. So impaction. So an impaction is where the stool is just so solidly impacted together that the person just can often not even have a bowel movement because it just won't come through. It's too large and it's too hard. And sometimes they have to be disimpacted, which is not a popular procedure to do at the hospital, but sometimes it has to be digitally broken up. And also impactions lead to straining. It leads to hemorrhoids. It leads to tearing of the anal canal, which is called fissures. So, it's really uncomfortable for the older person. So preventions, making sure people are drinking well, so hydration, making sure that they're getting up to walk, and early use of stool softeners. So I'm not going to spend very much time on this slide at all. It's more for you to look at. Believe it or not, I think I've seen questions on ATI related to this. I don't know what what else to add. You can look at it at your leisure. So the next slide's on Valsalva maneuver. In brackets straining. So when you do a Valsalva maneuver, you're actually straining. That's what. So if you were to bear down really hard right now, that's a Valsalva, right? So we don't always want people to be bearing down if they're constipated. Okay, we do sometimes want them to bear down if we want to try and convert an arrhythmia. So supraventricular tachycardia is a fast rhythm that younger people get, sometimes older people, but it's often in the younger age group, younger adults. And the Valsalva is one of the first maneuvers that we'll try to see if we can stop the arrhythmia. And really what a Valsalva does is when you're bearing down, it's stopping blood flow from returning to the right side of the heart, because you're increasing the pressure in your chest so much by bearing down that it's stopping the venous return to the right side of the heart. So it's not a great thing for an old person to be doing, because they're reducing preload returning, or the blood volume to return to the right side of the heart, which is reducing preload. And old people can faint and collapse from bearing down, right? So and it's very common for an old person to be straining while urinating or straining while constipated, and they just collapse on the toilet from a Valsalva maneuver. There's also other conditions where you really don't want people to be straining when they're constipated. So any head injury, well, as I said, if you're stopping flow from blood flow of returning to the right side of the heart, it's because of the pressure in the chest that you're generating. Then venous return from the brain and all the structures in the head will increase in pressure, and any structures below the chest will increase in pressure because venous return is being blocked. So head injuries, the ICP will go up. Any eye surgery, we don't want people straining. It'll increase their intraocular pressure. Okay, so to avoid constipation, we often ask them not to lift heavy objects because that's straining, or to bend over to tie up their shoes, because that is going to put is going to cause increased intraocular pressure. Cardiac issues, angina, recent MI, definitely don't want them to become constipated and straining. Same idea, reduced preload to the heart, which will put a strain on the heart by having reduced blood flow returning to it. Valsalva will definitely aggravate or even create hemorrhoids. Any recent abdominal surgery, if they become constipated and they're straining, well, they could easily tear through the wound that's been sewn up. So they're highly encouraged not to get constipated. Someone with ascites, portal hypertension. So if you have cirrhosis and you have portal hypertension and lots of fluid in your peritoneal cavity, straining is only going to aggravate that. So it's a good reason not to get constipated. Okay, so diverticulosis and diverticulitis. So diverticulosis is a condition in the large intestine, the colon, where you get these little outpouchings developing, and it often starts in your 40s. Can get you can get more and more of these little pockets, these little outpouchings of the bowel in your 50s and 60s, and it's very common in North America, and it's very related to our diet. We tend to have a low fiber, high high meat, animal fat type diet, and what that causes is the bowel, the large intestine, has to contract a lot over time because there isn't there isn't bulky stool. It's a low residue, low fiber, constipated type stool. So the colon is contracting a lot for many years. And all that contracting leads to higher pressures in the large intestine, and then you get all these little outpouchings called diverticulosis. Now, diverticulosis in itself is not an issue. You don't typically have any symptoms from diverticulosis. They're just the little outpouchings. It's when one of these outpouchings gets inflamed or infected that they become that you develop abdominal pain, fevers, and one of these pouches can actually form a small abscess when it's blocked. And that small abscess can actually break open and perforate into the peritoneal cavity, and you can develop perforation. So small abscesses and perforations can happen from diverticulitis. And we treat diverticulitis with antibiotics. We encourage people to, after the acute event is over, the diverticulitis has been treated, and we typically do a follow-up colonoscopy, and we see that there's diverticulosis everywhere. So we encourage them to have a high fiber diet, increased hydration, making sure that you're not getting constipated and that the bowel isn't constantly having to contract and create high pressures in the large intestine. Now there's a lot of myths and a lot of different ideas about how can you, if you have diverticulosis. By the way, most diverticulosis, most of those little outpouchings are typically on the left side of the colon, where the pressures tend to be higher because the stool is harder compared to the right side of the large intestine. So what's going to be the main symptom of someone with diverticulitis when one of them gets inflamed? It's going to be left lower quadrant pain, because that's where the descending colon and the sigmoid colon is, and that's typically where you get most of these diverticuli. So people often present with left lower quadrant pain, low-grade fevers, change in bowel habit. So they might say that there's something happening with my bowels. I'm more constipated than usual, or I have some diarrhea now with this left lower quadrant pain. They often have an elevated white blood cell count. If we really want to have a look at the area to make sure that there's no abscess formation, then we'll do a CAT scan to confirm the diagnosis and also rule out whether they have a small abscess forming. And as I said, the treatment is really antibiotics initially to treat the acute diverticulitis. And then advice is given concerning the high fiber diet, proper hydration, stool softeners sometimes. There's a lot of myths out there about avoiding seeds, avoiding little berries. I can't really answer that for you. None of it's really been shown to have any evidence behind it. I know many people with diverticulosis avoid small seeds, strawberries and raspberries, because they have little seeds in them. I can't really add any more evidence-based detail to that. Okay, so let's talk about hemorrhoids a bit. So I think I mentioned in an earlier slide that hemorrhoids are basically sacs of blood, sacs of venous blood. Okay, and they act as cushions normally during a bowel movement. So during a bowel movement, they're not usually enlarged, and they act as cushions as the stool is passing by. And you can have internal hemorrhoids. So you can see there's an internal plexus of veins, and then at the bottom there's an external plexus of veins. Okay, and they're normally there. Now remember that these veins drain to the portal system and then go to the liver, just like most of the gastrointestinal tract. So anyone with cirrhosis or portal hypertension, these are definitely going to be enlarged, and people with cirrhosis often have hemorrhoids. In actual fact, anyone with increased abdominal pressure can have hemorrhoids. So someone who's pregnant can develop hemorrhoids. Someone who has a chronic cough, someone who's straining against constipation, all of that increases intra-abdominal pressure and can lead to either internal or external hemorrhoids. You can't see internal hemorrhoids when you look at someone's bottom. You can see external hemorrhoids. So internal hemorrhoids, people usually come in with, I'm having some bright red bleeding, but you can't see them bulging or anything. So internal hemorrhoids can be a bit difficult because other things cause bleeding as well. So can't really assume that it's the internal hemorrhoid that's bleeding. It could be something else in the rectum or up higher. External hemorrhoids are very visual. They look like a very hard grape, or even much larger than that, and they're very tense. And when you press them, they're very tender. Okay, so let's just look at the risk factors here. So definitely constipation and straining will lead to hemorrhoids. Ignoring the urge to defecate is going to lead to constipation, so that'll lead to hemorrhoids. Straining, lifting, pushing, pregnancy, those are all things that increase intra-abdominal pressure. And we also mentioned anything that increases portal hypertension, such as cirrhosis. And what do hemorrhoids do? Well, they bleed. So if you have an internal hemorrhoid, as I said, it'll just be bleeding. Can't tell where it's coming from. If you have an external hemorrhoid, it'll be prolapsed, it'll be out, you'll see it, and often they're bleeding too. They're painful. So external hemorrhoids are painful. Internal hemorrhoids are not painful. There's no nerve endings there. They're not painful at all. External hemorrhoids are itchy. When you have a bowel movement, you're not able really to clean yourself completely. And stool stays around or in the crevice around the external hemorrhoid, and you become very itchy. So often we tell people to get in the bathtub after a bowel movement, or wash yourself properly with soap and water as opposed to just tissue paper, to avoid getting itchiness and skin irritation from the hemorrhoid. Okay, and the treatment for hemorrhoids is really the treatment for constipation first. Increase fiber intake, increase fluid intake. For the hemorrhoids, often they'll resolve by themselves. If they don't, there's techniques where we can put bands. It's almost like choking off the hemorrhoid by putting a rubber band around it. And when you band these hemorrhoids, especially the internal hemorrhoids, the band will stop the bleeding because it's kind of choked off the initial part of the hemorrhoid, and then the rest of it just dies off and falls away. So that's banding, hemorrhoid banding. And then if they're really bad, lots of bleeding, very large hemorrhoids, not settling down, then there is a surgery called a hemorrhoidectomy. Not commonly done because usually other things settle down the hemorrhoids. Okay, so let's look at the two different types of hemorrhoids. Okay, so you have your external hemorrhoids, which you can usually feel with your finger, right? They're tender, they're bulging, they feel like something has prolapsed from the anus. And now, they don't have to be bleeding, but if they tear or if they're open, then you'll have bleeding external hemorrhoids. Otherwise, if the external hemorrhoid is just there, it's going to be painful and tender, and you'll be able to feel it, but it's not quite bleeding, or it hasn't started bleeding anyways. And patients often come in and they're very concerned about a lump, a painful lump that they have around their anus. And invariably, it's an external hemorrhoid. Okay? And hemorrhoids are just collections of venous or venules, or we call venous plexuses. So just a collection of veins. And when they open, okay, we call them a bleeding hemorrhoid. When they thrombose, meaning they harden and clot, say in the external hemorrhoid, then they're tender and bulging and painful. Okay? Internal hemorrhoids we can't see. So patients usually present with internal hemorrhoids. They haven't become external, so you can't feel them. But patients usually come in and say, you know, I'm bleeding with bowel movements. Or I notice that I have blood on the tissue paper after a bowel movement. Or when I look in the toilet, I can see that there's a bit of blood on the stool. Okay, so they're not typically painful because they're inside and they haven't thrombosed, they haven't hardened. So most internal hemorrhoids, the symptom is asymptomatic bleeding. Okay, and it's usually bright red blood because it's very low down, right? It's right before the stool comes out, and as I said, it's on the tissue paper or it's on some of the stool, but it's not a painful condition like an external hemorrhoid. Okay, and this is the last slide of the gastrointestinal module. So enteric nervous system. So this is just a slide to remind you that the gastrointestinal tract actually has its own nervous system. It can run the gastrointestinal tract without external input. I mean, it gets external input from the parasympathetic system and the sympathetic system, but it can actually function independently. Okay, so the whole nervous system, or the whole gastrointestinal tract is lined with many nerve fibers that function independently, and they control the smooth muscle contractions to create the peristalsis that don't require any CNS, central nervous system input. As I mentioned, the autonomic nervous system can get involved and adjust the peristalsis in the gastrointestinal tract, but it'll still function independently. So I'm sure you remember this from the autonomic nervous system, that the parasympathetic, the rest digest system, will increase peristalsis and contractions to help process any food intake for digestion. the sympathetic system, the fight or flight system, will decrease contractions and cause the bowel to reduce functions temporarily. So the enteric nervous system is becoming more and more recognized as a nervous system of itself. So there's the central nervous system, the peripheral nervous system, and the enteric nervous system.